So good afternoon, ladies and gentlemen. Today is the last series of Ear and Hearing Care Symposium series. And our presenter today is Sarah Ndegwa. Sarah Ndegwa is a clinical audiologist, a lecturer in the University of Nairobi. And she's also having this session together with Nancy Kemunto, who's also a clinical audiologist in Kenyatta National Hospital. The topic today is early detection of hearing loss across the life course. So Sarah, welcome again to the platform. We're happy to have you. You may begin the presentation.
Good afternoon, everyone, and thank you very much for joining in on today's series. And the title of my presentation today is Early Detection of Hearing Loss Across the Life Course. Joining me later on in the presentation is Nancy Kemunto, who is a clinical audiologist at the Kenyatta National Hospital. So as an introduction, the outline rather, we're going to go through an introduction and then we're going to go into the topics of hearing screening across the life course, which is focused on newborns and infants, preschool and school-age children, adults at high risk of hearing loss, and older adults. So early identification is the first step in addressing hearing loss. Hearing loss is often referred to as an invisible disability and often remains undetected. It has negative consequences on rehabilitation outcomes and cognition. Therefore, screening for hearing loss should be targeted at different stages across the life course. Globally, 466 million persons are said to have disabling hearing loss, which is moderate or worse hearing. This is according to the WHO estimates of 2018. 34 million children live with disabling hearing loss, and 60% of childhood hearing loss is preventable. 31% is due to infections, 17% due to birth-related causes, 4% due to ototoxicity, and 8% due to other causes. As per the World Report on Hearing, various interventions were identified and the acronym HEARING was used. And the first word or first letter, hearing, refers to hearing and screening interventions across the life course, newborn, school, the at-risk adults, and the elderly, which is going to be the focus of the presentation today. The others are ear, disease prevention and management, A is access to technologies, R is rehabilitation services, I, communication, improved communication, noise reduction, which I think there was a session last week on safe listening, and G, greater community engagement. So what is the impact of hearing loss? People who have hearing loss have challenges in interpersonal communication. With hearing loss also comes social isolation and feelings of loneliness. And then in children of importance, it can lead to delayed speech and language development. And that is why any child who has a delay in speech and language development, but must essentially have a hearing assessment done to establish to rule out hearing loss as the cause of the delay in speech and language. This also translates to poor academic performance. And then later on in life, they have reduced employment prospects. Also, because of the language problem, they have delayed cognitive development. And then with hearing loss also comes loss of identity and quite a lot of stigma. Hearing loss has also been identified as a risk factor for dementia and cognitive decline. There's also an economic impact of hearing loss. It has been estimated by WHO that unaddressed hearing loss costs the world about $980 billion annually. This diagram is about the grades of hearing. So you can have hearing ranging from normal hearing to mild hearing loss, moderate hearing loss, moderately severe hearing loss, severe hearing loss, profound hearing loss, and complete hearing loss, which is complete deafness. So for normal hearing, the range is between, at least it's less than 10 decibels. And this one's, the experience is that the person will have no problem hearing sounds. With a mild hearing loss, the range is between 20 to 35 dB. And usually these people with mild hearing loss do not have problems hearing conversations. With moderate hearing loss, the range is between 35 to 50 decibels. And usually patients with this kind of loss have difficulty hearing conversational speech. With moderately severe hearing loss, which ranges between 50 to less than 65 dB, they have difficulty hearing conversational sounds, and one has to raise their voice in order for them to hear. When it comes to severe hearing loss, which is a range between 65 to 80 decibels, they do not hear most of conversational speech, even if you raise your voice, and therefore understanding becomes a problem. With profound hearing loss, that is 80 dB and above, they have extreme difficulty hearing any raised voices. With complete hearing loss, they cannot hear speech nor environmental sounds. So then what is hearing screening? Screening has been defined as a process by which individuals are identified who have diseases or disorders that would otherwise go undetected. The usual criteria for hearing screening is a pass and fail, and those failing the screening are said to be exhibiting signs of potential hearing loss. So it is possible to identify hearing loss at all ages and in all settings. So the question, therefore, is who should be screened? So across the life course, we have 4 different places have been identified as targeted cohorts or groups of peoples that symptomatic screening can be done. And this is newborns, children, and this is preschool and school going children, adults, and these are those who are at risk of hearing loss based on their occupations, and then the older adults, and this is due to just the aging process. So now let's talk about newborn and infant hearing screening. According to the Joint Committee of Infant Hearing statement or position statement on the principles and guidelines for early hearing detection and intervention programs, 1, 2, 3 has been identified as, let me say, a reference point as to how screening should be done. And so screening at 1 month of age, screening should be done within 1 month of age. That is now from birth, when a child is born, up to about 28 days. That is what is recommended. And then after that screening, if the child should fail the screen, although when we are doing newborn screening, we don't call it fail, we say a refer. So if the child refers, they should go on for diagnostic hearing assessment. And this should be done within 3 months from, 3 months. And then should the diagnostic assessment identify a hearing loss, then early intervention should be done no later than 6 months of age. So remember the 1, 3, 6, screening by 1 month, diagnosis by 3 months, and intervention by 6 months. So what are the screening approaches that we have? Newborn hearing screening follows 1 or 2 approaches. The first one is a universal screening, which covers all infants. And then you have the at-risk screening, what is also known as targeted screening. This targets the newborns who are at risk of permanent hearing loss. And we're going to go through some of the risk factors for hearing loss. So if you're doing targeted hearing screening, then that is the category of patients that need to be screened for hearing. So when neither of the 2 are available or feasible, then hearing screening can be done based on parental suspicion. And we're also going to go through a questionnaire which parents can have access to or know about, so that if they raise any suspicion, then the child should go ahead and be screened and diagnosis done. So a refer, as we mentioned earlier, result after the first screening should be followed up by a second screening, after which, if they refer the second screening, then they should go for onward diagnostic assessment. Some of the risk factors for hearing loss in newborns are a strong family history of sensory neurohearing loss, the in utero infections such as rubella, cytomegalovirus, herpes, syphilis, prematurity, low birth weight. These are babies who are below 1,500 grams, hyperbilirubinemia, meningitis, use of ototoxic medications, birth asphyxia, congenital syndromes associated with hearing loss, such as Treacher-Collins syndrome, Waardenburg syndrome, among others. And then consanguinity, which is hearing loss that is due to family members who are closely related getting married. That is like cousins, as an example. This is a checklist for hearing and speech. So a newborn should be able to startle to loud sounds. Between the age of 0 to 3 months, the child is soothed by moderately loud voice. Between 3 to 4 months, this child would turn towards the source of sound. Between 6 months to 8 months, the child not only turns, but they localize the sound source. And it's around this time that they begin to babble or make some bubbling sounds, such as da-da-da, ma-ma-ma. By the age of 12 months, the bubbling increases and the first word is heard, such as bye-bye, mama, and so forth. And then they also understand simple instructions, just like bye-bye, come here. By 18 months, they can say the child can say at least 6 words. By 2 years, they should be able to be joining now 2 words together. And by 3 years, they're talking now in sentences and their speech is mostly clear. So in screening, for this category of children, newborns and infants, we normally would use objective hearing screen tests. And those are otoacoustic emissions and automated auditory brainstem response, audiometry. These 2 tools can detect hearing loss averaging at least 30 to 35 decibels or more in the frequency region that is important for speech recognition and speech development, that is around 500 hertz to 4,000 hertz. So let's talk about otoacoustic emissions. Otoacoustic emissions are low-intensity sounds that are measurable in the external ear canal as a result of active mechanism of the outer hair cells in the cochlea. So with otoacoustic emissions, a probe is placed in the external auditory canal, and that probe has got a speaker and a microphone. So within a very short time, less than a minute, one is able to now record the otoacoustic emissions. If it is present, the result will be a pass. And if there is potentially a hearing loss, then the result will be a refer. And so, as you can see here, it can be just done in the maternity. All it just requires is for the baby to be quietly asleep. So it is done soon after birth, before the baby is discharged from hospital. We also do it in the clinic for some a little bit older children, even 2-year-old children. As you can see here, a baby of about 2 years also undergoing otoacoustic emissions test. And here we have a baby in the maternity ward just before discharge, having the OAE test conducted. Then there's also another objective test that is known as ABR, that is a auditory brainstem response audiometry. In this ABR, it's done in 2 ways. One, you can do it as a screening tool, in which case you just have a cutoff point that is 30 dB, for example. And the ABR test is appropriate for babies, especially those who have been in NICU for more than 5 days, because they have the potential of getting what you'd call auditory neuropathy. So then ABR becomes, in this case, we call it automated ABR, becomes a very good screening tool for them. So ABR is an electrophysiologic measure of the function of auditory nerve, the auditory pathway all the way to the brainstem. The responses to the auditory stimuli are recorded by placing 3 surface electrodes. And then, of course, you place now the transducer, the headphone. It can be an insert phone or a headphone, which is the one now that is presenting the sound to the child's ear. And then after that, you are able to record the readings. So in automated ABR, it will show you as a pass or fail or refer. If you're using ABR for diagnostic, on the other hand, the assembly or the electrode placement is very much the same. The difference is that now in diagnostic ABR, you're going to be able to tell the exact level of hearing loss the child has. Okay, the other thing that one can use if you do not have the objective test available is a questionnaire. And so in the questionnaire, there are certain questions that you can ask the parent. Or for example, in a few weeks old, some of the questions you would ask is, does your baby open his or her eyes when there is noise? Does your baby appear to be listening to you when you talk or sing? At about 6 months, does your baby try to see where the sound is coming from turning his or her eyes towards the sound? Does your baby enjoy you talking to him or her? About 9 months, does your baby appear to respond to even very soft sounds? And this is important because parents express this kind of observation. And so the clinician must be able to take note of that and send the child for hearing assessment. At about 1 year, does your child baby respond when his or her name is called? At 18 months, does your baby pick up or point to things around the house when you ask them to do this? Where is the dog? Where is the cat? Where is the cup? At around 2 years of age, do you think your baby can hear normally even when you speak to him in a very soft voice? These are some of the questions that the parent or caregiver can be asked. And if the answer to that is no, then definitely you need to refer them for hearing assessment. Okay, so that's about newborn and infant hearing screening. So then we have a hearing screening for school children. So the goal of school hearing screening programs is to identify children with potential hearing deficits at the earliest stage possible in order to refer them for diagnosis, treatment as required. The test should be simple to perform. It should require minimal preparation, and it should be cost-effective. So the screening protocol that can be used, if you're now using pure tone audiometry test, you can do frequencies 1 kilohertz, 2 kilohertz, and 4 kilohertz. And the screening intensity can be 20 dB HL or 25 decibels hearing level. And the number of presentations or tone presentations may be 1 to 3, but not more than 4. And the pass and fail criteria is a pass at all frequencies is in both ears at the recommended screening intensity, which can be 20 or 25 dB decibels hearing level. And then a fail or a refer at any one frequency in either ear requires a rescreen. And even after the rescreen, if they should still refer at one frequency in either of the ears or more, then they need to go for onward diagnostic assessment. There are also other additional tests that we do while we're in school screening. We do an ear examination, and this is aimed at identifying the common ear problems. And there are also smartphone-based otoscopy apps that can be used for this, or just your otoscope. Tympanometry, this is a test for middle ear function, and is very, very useful, especially in the diagnosis of otitis media with effusion. And then even in the school screening programs, you may also have otoacoustic emissions testing. This is useful where children are unable to follow instructions. For example, the preschool children or children with special needs, such as cerebral palsy and other conditions. So in the ear examination, again, we said you can use an otoscope or headlight to examine the ear. You're looking out for, is there impacted wax? Could there be a foreign body? Is there acute otitis media with effusion? Is there chronic otitis media? Do you see any swelling, any redness or tenderness around the ear? This should be referred for further management. So what are the advantages of doing hearing screening in a school setup? One, you have access to a large number of children of different ages, and it can be done within a short period of time. It is less expensive compared to service performed in another sector of the healthcare system. And you have also, number 4, the opportunity to screen children who have previously not been identified with hearing loss. As we said earlier, hearing loss is said to be a hidden disability. And so for a child with like a mild or moderate hearing loss may not have been identified because this child may already have speech, but they're not always attentive. A child who has a moderate hearing loss, listening to the teacher speak at a distance of even about 2 meters, they probably are not getting anything the teacher is saying. And so doing screening in schools is a great opportunity to identify these children with the mild, the moderate hearing losses. Sometimes the ones with severe hearing losses, the parent may already have noticed, but the mild to moderate actually go missed. And some of these children are branded as inattentive or rude and so forth because they do not respond appropriately when called and they seem to be ignoring, whereas in actual fact, they are not hearing. So then it also accords us the ongoing opportunity to be able to observe, assess, and investigate any potential areas of concern because the child is now there in that school. So how do we set up a school-based screening program? Important things to consider. One, you must have already established the procedures and the standards, so in the interest of best practice. And then training can be done for nurses, community health workers, even the teachers or other non-clinical staff or non-hearing care clinicians, and those who will now conduct the screenings. There must be provision of facilities for the screening, which of course include the equipment, but also the environment where this screening is going to be done. And so one would require to identify a quiet place within the school, a place where the sound level is no more than 40 decibels dBA. And then fourthly, after the screening, because it is not enough just to screen, then what? You must already have identified a health facility where referral can be done, follow-up, diagnosis, and treatment of the referred cases. And there must also be involvement of the parents and the guardians in terms of even first place. The host has muted everyone.
You can go ahead. We can hear you.
Okay. Sorry about that. So best practice for hearing screening. So we talked about screening test should be accurate and reliable. So your equipment must be well calibrated. Secondly, the environment must be appropriate for screening. There should be no noise. It should be a quiet place with noise levels no more than 40 dBA. And then you need to have trained and qualified personnel performing the screening. So even if they are the community health workers or they are non-clinicians, they need to be very well trained in conducting this screening. And then referral mechanisms need to be in place so that those referred can receive diagnosis and appropriate treatment. Then the screening results should be communicated by the person who's screening in a way that can be understood by the parent, and so that then the follow-up and the continuum of care can be put in order. And 6, effective treatment and early intervention should be instituted. And finally, you must provide information materials. This would be very useful. And one example is after screening has been done, for mothers, you can write in the MCH booklet that screening was done and the child passed or was referred. And now for the school-going child, you can get some information about hearing. It's good if you can provide that to them. Okay, so now we are coming into a hearing screening for older adults. And I'd like to invite my colleague, Nancy Kemunto, to take us through this next part.
Good afternoon, everyone. We are going to go through hearing screening in older adults. So hearing loss is the third most common chronic disorder affecting adults and the elderly. And most of the time, they also do not notice that they have the disorder until somebody points out to them that there's something wrong with your hearing, or people have to repeat themselves regularly. So the global burden of disease estimates and suggests that over 65% of the global population aged over 60 years experiences some degree of hearing loss. So age-related hearing loss is associated with age and age-related vestibular dysfunction, which also predisposes the individuals to higher risks of falling and exposing them to even more secondary difficulties and making their life hard. All adults from the age of 50 should be screened regularly for hearing loss so that intervention may also be done early enough. Screening may be conducted at a 5-yearly interval until the age of 64, where now we can begin to screen them annually after the age of 65. Hearing screening schedules should be aligned with wellness and health screening checks. Especially those who go to special clinics, this should be followed forthwith. There are different, screening of adults at higher risks. Depending on where we are as adults in terms of work, in terms of leisure, in terms of life, we are exposed to different risks of hearing loss in our daily endeavors. These may include adults exposed to noise or ototoxic chemicals at the workplace. An example of these are the Juakali artisans who work without ear protection, and matatu industries where more especially the driver and the conductor who stay in the matatu that is noisy for a whole day and do not have any kind of protection to their ears. Then we have the factories that make chemicals that are used either for domestic work or different settings in the environment, but now to them, they don't know that the chemicals also expose them in terms of ototoxic. So the factories should have the guidelines, the occupational setting should adopt conservation guidelines as outlined in the noise reduction guidelines so that it can protect its workers. The part B is those who adults who are receiving ototoxic medications and treatment. For example, cancer patients, those patients who are prescribed ototoxic medication like aminoglycosides. This prior, during, and after getting the cancer treatment medication, the clients should receive hearing tests so to avoid risks. Also, the patients who are getting cancer medication should also have the hearing test so that the dose may be adjusted accordingly to avoid ototoxicity. TB and HIV programs should incorporate hearing screening in their routine programs. They should put also the guidelines in there for the community health workers to do basic screening in the community. This will help to avoid ototoxicity because they take medications for a long time. Adults with comorbid conditions affecting hearing, for example, diabetes and hypertension. The special clinics in the health facilities should include hearing screening as part of their routine checkups to identify and early intervention to be put in place. A red flag alert following screening indicates the need of expert attention and can result from a history of rapid progressive hearing loss or unilateral hearing loss of unknown origin. 2, exposure to noise either at work or at recreational activities or ototoxic medication and chemicals. That is another red flag. Another one will be a complaint of ear pain, ear discharge, and lastly, pre-existing diagnosis of diseases such as chronic otitis media. Some of these these are very common red flags that we should look out for. So in all the adults, hearing screening should be followed up, and it should be done promptly by giving hearing aids as intervention. And this is associated with significant improvement and hearing-related health outcomes. We should, when these older adults also get that their environment is improving in terms of hearing, they'll also be socially involved and will not having progressive diseases like maybe depression. So where will we get the site for screening? So screening can take place in a variety of settings, including clinical settings, community settings, home settings. Those who obtain a refer at the settings are referred to at an audiology center for diagnostic testing and rehabilitation. What are the tools that we use when we are doing the hearing screening? The conventional methods are 1, pure tone audiometry. We can also use voice test and a questionnaire, the one that Ms. Sarah highlighted above. So what are when we are doing pure tone audiometry for hearing screening, the test frequencies that are tested are 0.5, 1, 2, and 4 kilohertz. When doing the voice test, one should stand about an arm's length away behind and to one side of the patient. Reach around and close off the other ear by pressing on the tragus. Whisper words in a soft whispered voice. If the patient repeats what you have said, the patient can hear and then repeat, then the patient has a normal. If the patient has repeated what you've said, then the patient has normal hearing on that ear that is not covered. You will also repeat using the same on the other ear. And by this, when you're continuing to do this, you'll also use varied voice levels, conversational voice, loud voice, or shouted voice, and record appropriately. The questionnaire, the hearing handicap inventory for adults questionnaire that was highlighted at the previous slide can also be used for adults also. Hearing screening technology-based solutions. What are some of the solutions that are usually used? We have technology-based solutions, that is automated hearing screening, smartphone-based software application, boothless audiometry, and also telemedicine. In the automated hearing test, this reduces the need for training as the technology used can be programmed to provide the signal and analyze the individual's response. You can see some of those, the pictures of different technology that is being used. You can see the otoscope being used by a phone, the phone otoscope. You have the phone testing like audiometry, screening audiometry. Signals are given by the phone, and the headphones get the signals through the headphones, then the different levels of voices. We also have other different apps that can be downloaded on the phone, so that, and they are quite easy to use. You just follow the instructions and it does the test appropriately and records. So one of the apps that is used widely is the HearWho app that is based on validated digits in noise technology. It gives the general public access to a free validated hearing screener to check their hearing status and monitor it over time. It is an easy to use app. It clearly displays the user's results and keeps a personalized tracked record of their hearing status over time. It is available on both Android and iOS formats, and you can easily download it and follow and use it. So the boothless audiometry, it has no sound, and the use of noise cancellation headphones can be used. In telemedicine is the delivery of health-related services and information via telecommunication and technology. Audiological findings and otoscopic images are transmitted over the internet from the individual to an expert at a remote location, and appropriate rehabilitation or treatment methods are given via the phone. Thank you very much.
Thank you, and that's the end of our presentation. We invite questions.
Yeah. So thank you very much, Sarah and Nancy, for the presentation. Kindly post, I think we'll enable the chat box now so that we can have all CPD questions on our chat bot. Nelson, if you can be able to do that, it would be better. So we can just have questions on this particular CPD, on this particular webinar on the Q&A platform.
There's a question here that I'd like to answer. The question is, if a person has hearing loss after having been slapped in the ear, so what normally happens, depending on how bad the slap was, what can happen is that you can get a perforated tympanic membrane or eardrum. And so depending again on how big the perforation is, the management will be dependent on that. So most of the people who get that kind of trauma as a result of a slap or hearing loss that has resulted from a slap, most likely is a tear of the tympanic membrane. Sometimes it can also be, depending again on how severe it was, it can also be not only a perforated tympanic membrane, but also can result in sensory neurohearing loss. But most times it is usually a perforated tympanic membrane, in which case they just go to the hospital and they're treated. Usually for that, you will not get topical antibiotics. Usually it's oral antibiotics and painkillers, and then of course now follow up. So that is the reason why they will more than likely have a hearing loss, because of that perforated tympanic membrane. The next question. In screening, why don't you use?
Okay, Sarah.
Yes.
Yeah, so I just read out the questions for you so that it's a bit easier.
Easier. Okay.
Good afternoon. If a person loses his or her hearing because of GBV, where the person was slapped at the ear and now has a hearing disturbance, and one has to shout for them to hear even in a silent environment, what will be the solution for this? So I also have a question. Would this categorize as an noise? What type of hearing loss is this?
So this is more. So the ear is divided into three parts. You have the outer ear, the middle ear, and the inner ear. Hearing loss that is resultant from problems in the external auditory meatus or in the middle ear result in what you call a conductive hearing loss. Conductive hearing loss is usually managed by either medication or surgery. And then the inner ear, hearing loss that are associated with inner ear problems, that is now the cochlea and the resultant auditory nerve, that we refer to as sensorineural hearing loss. In this particular case that you are talking about, the slap, more than likely because of the pressure in the when you slap, there's a lot of positive and negative pressure which tears or perforates the eardrum. Now, the management for perforated eardrum because of that traumatic perforation will be, usually it is medical, and now which would be like antibiotics and painkiller. But if the perforation is large, let's say a subtotal perforation, again, it's a conductive hearing loss because it's the tympanic the eardrum that has been perforated. It may require surgery, which is now what you call laryngoplasty. If the ossicles, the middle ear bones are affected, then you'll do a tympanoplasty. So it really depends on the extent, but majority of the cases of the slap would result in a conductive hearing loss. And the level average would be anything between, well, mild to severe, depending on, how much the intensity of that slap. Thank you.
Thank you for that. Then a lot of questions on impacted works, but I think we can address that later. There was one question on screening. Why don't we use 8K frequency? Is there a particular reason?
Okay, recall that this is hearing screening. It's not necessarily diagnostic. And so unless you are doing specifically for what you call ototoxicity, we don't really need to go to 8 kilohertz. If 4 kilohertz can take care of any signs of ototoxicity or even noise-induced hearing loss. So usually we don't necessarily, so it depends on the setting. If, for example, you are doing hearing screening for factories, for example, then you'd have to go to not only, you do 0.5, 1, 2, 4, 3, 4, 6, and 8. So it depends on your setting. So for children, if you can get 0.5, 1, 2, and 4, which are the most important as far as speech is concerned, if then there is a problem, then that's when you do onward. It's not diagnostic, this is a screening test. But if you're doing screening in like occupational screening for hearing loss, then you would include 8 kilohertz. But more importantly, the frequencies that you'd want to include are make sure that you have 3, 4, 6, and 8 kilohertz.
Okay, that's well noted. At what age can a child learn a second language? I'm assuming we're associating that with hearing, but maybe Sarah, you can expand further.
So children actually can learn all languages at, as they're beginning to learn their first, second language, they can just learn all of them together. So they will pick one word from this and another one from this, and they'll get more words depending on their exposure. But they learn language, you know, a child begins to hear even from birth. So they will be able to, within the first year of life, they are basically hearing, and then they begin to speak their first words around 1 year of age. And it can be as many languages up to, at least I know 3 languages at least, they can be able to pick quite well.
Ah, nice. So maybe Sarah can answer this because she, Nancy, she can answer this. What's the hearing loss is the third most common chronic disorder. What are the other first two?
Sorry, come again.
Hearing loss is the third most common chronic disorder affecting adults. What are the other first two?
I would guess the other first two, maybe I get back to you, but I think it's cardiovascular and diabetes, I think.
Okay, I guess that's Tihani Kwetu. We'll look for it and actually update everybody on that, probably
Sure.
in the next forum we have. What causes sounds of breathing in 1 year? I'm not sure if I understand the question, but maybe you do.
I think you're talking about tinnitus. Did you said sounds of breathing?
Yes, sounds of breathing.
Okay, so that is tinnitus. Tinnitus is when you hear a sound that in the ear or somewhere in the head that is not originating from the external. You kind of hear it inside. So we have 2 types of tinnitus. You have the subjective tinnitus, and then you have an objective tinnitus. Most times people will complain over subjective tinnitus. This means that you can hear that noise, but somebody else or your clinician cannot hear it. So in that one, the majority of people with subjective tinnitus have a hearing problem, whether it is mild, moderate, severe, but have a hearing, problem. There are also those who have that tinnitus, but you don't necessarily have a hearing loss, but most of the people have a hearing loss. So in which case, you just need to have your ear examined, and of course also do a hearing test so that we identify where the problem is and manage it accordingly. Then you have also objective tinnitus. For example, if you have, a carotid body tumor, you can auscultate around the ear and you can hear a bruise sound. So, and usually those ones are pulsatile. It's like the heartbeat, like that. So that one now needs to be referred and investigated more because it's an objective type of tinnitus. But by far the majority, it's because I said it's because of hearing loss. So you identify the cause of hearing loss. As you manage that, you will also be able to manage now the noise that they hear, which is now what we call tinnitus.
Yeah, so just expounding on that particular question, what causes pain at the ear surrounding radiating to the right temporal? There's also a question like that.
Pain radiating from
the temporal part of the ear. What causes pain at the ear surrounding radiating to the right temporal?
Okay, you can have a problem of the temporal mandibular joint. It can give you pain in the ear, or you can have any, what is it, like an abscess or, a mastoid abscess or anything, you will get pain in the ear. It can also be pain from within the ear. Let's say you have a boil in the ear, furunculosis. So all infections can cause that, or joint problems. Like I mentioned, the temporal mandibular joint problem can give you a radiating pain around the ear.
Okay, can using earphones lead to hearing loss? And also, is getting pregnant above 40 years a risk factor for my baby getting hearing loss?
Yes, when you use earphones and you're putting the sound loud and exposing yourself for more than even an hour, you lose about almost 60% or 20% you lose about 20% in every hour that you are exposed. And this comes when you use more than 60% of the volume that you use in the earphones. Getting a child above 40 years, age alone does not really predispose the child to hearing loss. There are so many other predisposing factors that were highlighted by Sarah in terms of risk to hearing loss with the baby. So the age factor alone is not the only risk to having a baby with hearing loss. Going back to the earphones, if you expose yourself to more than 85 decibels for more than 2 hours or even an hour non-stop, you lose about 20%. So keeping it less would be better.
Sorry, I didn't quite get the risk factor, it being a risk factor for hearing loss.
The age.
Yes, because those are two different questions, but from one person on if you get pregnant above 40, is it a risk factor for the baby having hearing loss?
Having the baby at when you are above 40 years is not the only risk factor. If you have other conditions during pregnancy, or you have hypertension, you have diabetes, even during the antenatal period, if you have other infections like syphilis, can also make the child have hearing losses. So there are very many factors to consider in terms of hearing loss while getting pregnant at more than the age of 40. During birth, the baby can also have birth asphyxia, can also be underweight, can be premature. That will also have a risk to hearing loss. So it's not only having a baby at 40, above the age of 40 years. There are so many other factors to look around at.
Okay. Then there was a question on does the early fitting of hearing aids slow the rate of cognitive decline?
The way we can put it is that the fact that when you intervene or you treat the hearing loss, then you slower the rate of cognitive decline. Because you know what happens is that when you have a hearing loss, people tend to isolate themselves because of issues such as stigma. You're not hearing what people are saying, so you're not engaging people quite a bit. You tend to be quite isolated. You're not getting the kind of input that you require for your brain to be thinking and so forth. So once you take care of that factor by bringing back your hearing, and that is now through hearing aid, then you can infer that it can slow down that rate of cognitive decline. If the factor is because of lack of that stimulation, you know, by hearing and getting into conversations with people, if you're in school, if you're whatever it is that you're doing, engaging with your society, if that is cut out, one tends to have a faster cognitive decline as well as also earlier dementia. So it is a risk factor. Both of them are, I mean, it is a risk factor for both. So it is important to treat the hearing loss early enough. So yes, we can infer that it can slow the rate.
Yeah, but if I'm understanding you correctly, it will improve cognitive because if you don't hear properly, it will reduce.
Yeah,
okay.
That's what I mean.
Yeah. Then just a question, just for formality purposes, for us to get a better understanding and for repeating purposes. How many types of hearing losses do we have, from noise-induced and other types?
Okay, so basically hearing loss has three main types of hearing loss. One is a conductive hearing loss. This is associated with problems that are from the outer ear and middle ear. So from the outer ear, you can talk of anything like, for example, you may have wax, a foreign body there, infection, otitis externa, even a growth out in the middle, in the outer ear, or even you can have atresia, meatal atresia. You can have external auditory stenosis, anything that is causing an obstruction of sound getting through, that will give you a conductive hearing loss. Then when we come to the eardrum, then you can have either a perforated eardrum. Then you can have middle ear problems. Middle ear problems could be the one which is very common with children, otitis media with effusion. The middle ear cavity is supposed to have air. So when you have otitis media with effusion, there is fluid. So naturally the vibration, sound vibration is impeded, and so you will have a hearing loss. Then there are other things that, other structures that are in the middle ear, like for example, the ossicles, the malleus, the stapes, and the incus. If those bones are stiff, what you call otosclerosis, then you will have a hearing loss. You may also have an accident and then you dislocate one of the, one of those ossicles, let's say the incus stapes there, incudostapedial joint, you get discontinuity, you will get a hearing loss. You can also have trauma and then you have blood in the middle ear cavity, hematoma there. And you can also have a tumor, there's some middle ear tumors. All of those things can give you a conductive hearing loss. Then you have the hearing loss that is sensory. Sensory refers to problems within the cochlea. And then neural is now the auditory nerve. But usually we just refer to that as sensory neural. When I forgot to mention one of the most important causes of conductive hearing loss in our setup, which is chronic otitis media. So that's one of the important ones. So conductive hearing loss is, all those are some of the causes of conductive hearing loss. Then you have sensory neural hearing loss. And so here we are talking about the outer hair cells, middle ear cells being affected to various levels, giving you mild, moderate, severe hearing loss. And that can be caused by medication, ototoxic medication, can be caused by sickness like meningitis, severe malaria, presbycusis, age-old deafness, noise-induced hearing loss, which we are going to talk about a little bit more. Some medications like even chemotherapeutic drugs, loop diuretics, cisplatinum is one of the important ones. So all that gives you a sensory neural hearing loss. Neural, the nerve, usually the commonest one is an acoustic neuroma. So that causes sensory neural hearing loss. Then you can have a mix of the two. You can have an element of conductive hearing loss and also a bit of sensory neural hearing loss. So we call that now a mixed hearing loss. So in summary, you have conductive hearing loss, you have sensory neural hearing loss, and you have a mixed hearing loss. When it comes to noise-induced hearing loss, first of all, it begins as what you call a temporary threshold shift. Means that you lose your hearing when you're exposed to sound levels that are over 85 dB, and then the hair cells, they sort of recover. So, but persistent exposure to that kind of environment will lead to a permanent sensory neural hearing loss. And the usual frequency that is affected initially is the 4 kilohertz, 3, 4, 6. Actually, there is in the audiogram, which is the graph that we do for when you do a hearing test, there is normally a dip, which we call the 4 kilohertz notch. So that's what happened. Obviously, if it is are we still on? Obviously, if it is an extremely loud sound, like that of a bomb blast, you completely lose all your hearing. And so that one will result in profound deafness at the get-go. Yeah, thank you.
Thank you. That clarifies a lot, especially how you slid chronic otitis media being one of the most common causes of hearing loss. However, there seems to be a lot of questions on impact of impaction, wax impaction. And I was also wondering how common is it? Because it's a temporary one, not a permanent one per se. But is it also one of the most common reasons why people come in as presenting as I have a hearing problem?
So the way I'd like to say that is that let's start from school-going children. It is second to otitis media. Wax would be a very important cause of hearing loss. Remember, the hearing loss that is resultant from wax usually will be more or less a mild hearing loss, but nevertheless, it can still be a problem for children and even, of course, adults. And so impacted wax is what usually is a challenge. And it is common, I can say, especially in school children, going children, and also the older adults. That too is a problem. And it is quite a common one in our setup. You get it quite a bit. The other category of people who wax is important to look out for is those also who wear hearing aids, because wax generally is useful because it acts as a lubricant in the ear and so forth. And it migrates out all the way to the external ear at the opening there. So if you put in an ear mold, you kind of are interrupting that process. And so wax tends to build up now in the ear canal. And so for patients who have hearing aids, it's important, of course, for them to be checked at least after 6 months. You know, if there's any wax buildup, we clean it out for them. So where wax is impacted, it's quite simple. Syringing is a very simple and a procedure to conduct. And that's all that is required. Of course, you use softeners, wax softeners. We also use, usually we use hydrogen peroxide. We just put it and give the patient a few minutes, and then you're able to wash it out without much pain. So wax is really quite easy to manage. The syringing is usually done, especially when you have impacted wax. If it's not too much wax, just the white wax softeners are actually adequate. It will just drain off. But when it is impacted, it has to be washed out.
Take-home message for the people who clean their ears with the earbuds. What do you have to say to that?
Now, we say that the biggest thing that what you can put in your ear is your elbow. That's just a common saying. So all to say that really you shouldn't put earbuds into the ear canal, because one, when you do that, you tend to, first of all, you tend to impact the wax even more. And there's also the danger of perforating the eardrum. And we have seen quite a few cases of that even, you know, in the clinics. So if we do not recommend, basically the bottom line is we do not recommend the use of earbuds. And if at all you have to use them, it is just for the pinna, the external, the auricle, just cleaning up the auricle behind the ear. But putting anything in the ear canal is a no-go area. So that includes your biro tops, pens, feathers, and all those kind of things. If some people say, oh, I'm feeling very itchy in my ear, you can just rub your triggers against the ear canal, and that should suffice. So the message on that one is that do not put anything in your ear. Besides, also with these sharp objects, you also break the lining of the external auditory canal. You can introduce infection and so forth. So do not put anything in your ear. Just if it's a lot of wax, let the clinician clean it out for you.
Okay. So question on stem cell therapy. Does it offer a cure to mild or moderate hearing loss in adults?
To be honest, I know that there are studies around that, but I can't say conclusively in this forum that I can, can say with authority about it. All I can say is that at the moment, it's not available clinically, so that we don't have like cases where we can report about, even including for those who have profound deafness, the mainstay of management for those ones is the cochlear implant. So I know that there are studies that are still being done, but I cannot report here that there is any conclusion around that, or that I know that it has been used to, reverse hearing loss.
Then can perforated eardrums be fully treated without hearing aids?
Absolutely, absolutely. Perforated eardrums, remember, is mainly the tympanic membrane that has a hole. So that hole is just repaired by what you call laryngoplasty, and then the hearing, which is a graft is placed there. And so the hearing just comes back to normal. And if the bones in the middle ear are affected, that one also is managed. So yes, the answer to your question is yes, it can be completely repaired and the hearing comes back to normal. However, if for example, you had a subtotal or total perforation due to chronic otitis media, and it has gone on there for a long time. So it's no longer just a conductive hearing loss, but some toxins have gone into the cochlea and resulted in sensorineural hearing loss. Then that changes the management for that particular patient, in which case you will repair the eardrum to control the disease process, but there was already the inner ear which was affected, in which case then you require to give a hearing aid. But a simple perforated eardrum, that one, just repairing it surgically should resolve the problem and the patient should be able to hear well after the graft has taken very well. But if it has already been there, a process that has been going on for a long time, like COM, affection of the inner ear, sensorineural hearing loss, you will just treat the outer ear, the tympanic membrane, do the laryngoplasty, and then the patient may require hearing aids. And you will see this one is, for example, that kind of a patient will be having a mixed hearing loss. Means the hearing loss has an element of conductive, which is now related to the tympanic membrane perforation, and sensorineural, now which some of the toxins may have gotten to the cochlea and caused some loss there. Yeah, thank you.
Thank you. And then now the question from another person is, what is the cause for, what are the reasons for low hearing aid uptake using adherence?
Okay, there are so many different factors. Let's just even start from awareness. There's probably not adequate awareness that there is a solution to the hearing problem. So some people just do not know what they can do about their hearing loss. Then there is the stigma. That's one of the big hindrances, stigma. Some people have the notion that, you know what, if I wear a hearing aid, that means I'm old, so I'm not old, I'm not going to wear a hearing aid. And the usual thing in society when it comes to, when someone has a hearing loss, we think that, like they used to say, I don't know that they still say it, I hope they don't, deaf and dumb and those kind of demeaning kind of words. So stigma is one of, I think, a big hindrance. So you don't want to be in the way society sees somebody who is deaf. They don't think you're intelligent. They don't think you are, that kind of barrier. So one would shun, even when they know they have a hearing loss, getting help. And so a lot of education is required in that. Just like for glasses, well, most people, when you wear a glass, you look clever. When you wear a hearing aid, it appears that you don't look so clever. So that is just a stigma, and that which is not even true. And so we need to debunk all that. So we need to address the issue of hearing loss, the stigma. Then again, there is the aspect of cost. Hearing aids are quite pricey. And so that is one of the things that when we did this national strategy, we included them in the list of commodities or products that will be available to people so that they can be able to get it at least low-cost hearing aids, good quality, but low-cost hearing aids. So even that's the availability and affordability of hearing aids. It has been always a challenge. So that is how we are trying to address that. So those are some of the few reasons why there is a low uptake.
Okay, then there's a question on, can you elaborate on what you said about hearing on married cousin?
Sorry, what was that? On what? Sorry?
Married,
I see.
I guess, yeah.
Oh, consanguinity. Yeah.
Yes.
So there are certain communities who marry close relatives. Let's say you marry a cousin, whether maternal or paternal, and then even so that has been associated with hearing loss. And so what is important for that is to do genetic, to do counseling and to make some of these communities aware. It's just communities who marry very close relatives stand a high risk of now developing sensory neural hearing loss and syndromes. Yeah.
Okay. Another question is, I have a child with massive adenitis. Is there another remedy without surgery?
Adenitis. Oh, wow. That I think they are probably referring to adenoid hypertrophy.
I think so. Maybe we can pass.
So for that one, really, to be honest, you just need to see an ENT, and it is important because there can be a lot of effects of not intervening, because you can imagine the nose is blocked, the child is trying to swallow, so they'll have poor feeding, snoring, mouth breathing. So I think you stand best advised by your ENT, rather than just say you fear surgery. If at all it is really obstructing the nasal pathway, I think that at the advice of your ENT, and of course they are going to do things like, for example, an X-ray to see how much the obstruction is, then you stand advised or guided by just seeing your ENT doctor. So an X-ray, postnasal X-ray will be important for that. And of course, there are the symptoms now of mouth breathing, snoring at night, maybe poor feeding, vomiting, and so forth. And the growth of the child is not good. So, yeah.
Okay. Kindly comment on emergency removal of foreign body in the ear.
Emergency removal of foreign body in the ear. So, depends. Most of the foreign bodies in the ear can be removed by a clinician who knows, what it is, whether it is a bean, with a stone, and so forth. So some of the removals can be using instruments, or it can be through just syringing. But in the risk of something getting into the middle ear or perforating the eardrum, then that one definitely has to be removed in theater. Because of it is extremely painful and it's not even feasible to do it. So most of them can just be removed in the outpatient clinic, but some of them have been, somebody may have attempted and pushed it further on, even including perforating the eardrum, and now it is in the middle ear cavity. So then it has to be removed surgically. But almost really, by far the majority of foreign bodies are just removed, either, like we said, either using the probe, the crocodile forceps, or syringing. Yeah.
Okay, thank you. Good. Then another question from Anastasia. Can an already existing hear loss be managed? How is it managed?
Yes, it can be managed. The first thing really is to find out what is the cause of this hearing loss. So depending on the cause of the hearing loss, let's say we mentioned a few things that can give you a conductive hearing loss, even the one we're talking about, wax and so forth. So if you can remove whatever is causing the hearing loss, then you have managed that hearing loss. But if the problem is a sensory neural hearing loss, it can also be managed, but now again, it will depend on You know, the sensory neural are permanent. So for those ones, it's usually rehabilitation, in which case you will need hearing aids. And if the hearing loss is severe to profound, then you will need a cochlear implant will be the best option. So the answer to that is yes. At whatever point you have, you're diagnosed with a hearing loss, there is always a solution for it. It can be managed.
Okay, and then I'm not sure if I follow, but Judith was asking, does it mean that people with HIV and TB are at a higher risk for hearing loss?
I'll answer that. Yes, because number one, they are taking medication chronically. They are taking medication for a long time, and there are some TB medication that are ototoxic. And because they are taking it for a long time, they need to be monitored. They need to have a prior test before starting medication. In between treatment, they should also have a test so that they monitor the hearing. And also some HIV drugs have also been found out to cause ototoxicity, and some have hearing loss. So during their taking of medication, they should be regularly checked for hearing loss so that intervention is done at an early stage. So yes, it's a risk to hearing loss. And also, HIV are also predisposed to otitis media, herpes zoster, those conditions because of their immunity, their lowered immunity. So they are also exposed to other infections that increase the risk to hearing loss.
Okay, then the other question was on, thank you, and I think it's I guess probably we'd go with the sentiment of any disease that requires long drug treatment can easily cause hearing loss. Would that be correct?
Yes.
Okay. Then for hearing loss now from the impacted works, especially in the children, is it associated with hearing loss? I think we answered this, but delayed speech, but it's probably good to revise the question.
The good thing about the hearing loss, fortunately, although still a problem, is that usually it will cause a mild hearing loss. But remember, for a child, especially if they are developing speech or they're in school, even a mild hearing loss can interfere with their learning in terms of hearing. And so it is important that if you notice, that is why we actually have those stages where children can have checkups and the school health programs. That's what we are advocating for, because we are able to pick that early. In some cases, it doesn't always mean they will require syringing. Remember, we said it is when it is impacted wax that you can syringe. If it's a little bit of wax, the clinician can clean it out. And so, yes, it is important. A prolonged period of time with this child having, let's say, impacted wax, nobody has noticed, that mild hearing loss can affect their studies and to some extent also speech and language.
Okay, then lastly is regarding the use of analgesic ear drops. Which one would you recommend apart from orals? Which one would you recommend?
For the ear, we normally just take oral.
Oral, yeah.
Yeah, it's more effective.
And I think it was covered well by Dr. Lillian, so you could go to YouTube and check out. In the course of the week, we'll be done with uploading most of the sessions, so you can also listen in case you missed it. Dr. Lillian had actually elaborately talked about the use of painkillers in hearing loss. Then there was a question on the policies and guidelines, and I wanted that to be the last because we wanted to know where can we be able to get it. Is it already uploaded, or when will it be uploaded on the MOH website for the audience to benefit?
Should I go ahead and answer that?
Yes.
Okay, so that's actually what's ongoing right now. There are just a few polishing things that we are doing with the strategy as well as the guidelines. So we just wanted to add a few other things, and the Ministry of Health should be updating this on their websites by
I've lost you, Sarah.
mid next month, after we are done some of the additional, a few things here and there. Sorry. Hello? Can you hear me?
You keep breaking.
Okay. Can you hear me now?
Yes.
Okay, so saying that we are going to upload it very soon, but we are still just cleaning up. So by mid next month, it will be on the website of the MOH.
Okay, mid next month, no problem.
Yes.
As soon as you upload it, we would circulate it on our social media handles so that people can be updated on it. I think, Sarah, you can give me a buzz so that I'm aware and I can do the circulation in terms of communication.
I shall do
Then,
that.
yeah. So today is the end, Sarah. What are your What's your I normally ask you your take home message, but today it's not only a take home message, but what's your summary of all this series and the engagements you've had with the different audiences?
The first thing is I really do want to thank you for inviting us and allowing us to be able to speak to this audience and be able to share them what is happening in the world of ear and hearing care. Thank you for the wide reach. I think we've been having very many participants who are actively involved in asking questions. And this to us comes as a great joy, considering that one of the things we wanted to do, even with the national strategy and the policy guidelines, is to be able to disseminate this information, and so that the citizens can be helped and that we can be able to help in achieving the universal health coverage. So we thank you for allowing us this opportunity to be able to create awareness, to be able to share the information that we have in around the area of ear and hearing care. And the kind of the participants have been very engaging. We ourselves, and I speak on behalf of all the panelists who have been here, we have enjoyed doing this, and we hope that you can still invite us again. There is still much more that we'd like to share, especially in the line of rehabilitation. We have topics on speech and language, and so we have really enjoyed, and so we really appreciate this engagement and the opportunity that you have given us. And so I speak on behalf of Dr. Moko, who has been here earlier, Manasseh, Bocha from the Ministry of Health, myself, and Nancy Kemunto. So thank you so very much. We thank you.
And on behalf of KMH and I believe all the audience here, we are really grateful, and God bless you so much for the work that you've done, for the committee, and the deliverance that they've done and the awareness that they're creating amongst us healthcare workers. In all honesty, I've really enjoyed moderating these sessions because I've learned a lot, especially on our future. I hope we will not have a deaf future, but a bright one, and
Yes.
one that we are able to hear. So thank you very much, Sarah and team, for taking us through all of this. I just wanted to update. Tomorrow we'll be having a session on overview of the CML program in Kenya. This will be done by the Ministry of Health together with Dr. Angela Makligoi, who is from Kisumu, or is it Kakamega? Yeah. Then regarding the CPD points, I think I've mentioned it severally. The KMPDC was updating the website so that now, instead of you uploading your CPD points, immediately this is done, we'll just send the emails and names and numbers of everybody who's attended for more than 30 minutes, and it will be automatically uploaded on your site. So from now, henceforth, that's what will be happening. We are sending an email to everybody to update their registry, because we've noticed that there's a significant number of people who have not registered correctly. So like their board number would not be like, instead of a 0, they write an O. So you probably need to update the registration. So we're going to do a mass call out to everybody so that they can be able to do that. Then for KMP, for the PPB, I think Nelson had shared, and there it is, all the sessions that have been uploaded. Kindly make sure that you are using your registered email to be online. You're not using somebody else's, and you're using documentation that makes sense. Then you can easily be able to get the points from this particular channel. There's on and off problems with PPP, so you'll have to probably bear with us, but it will work eventually. Then we have, of course, the clinical officers. We normally usually send it and award it from the portal, and I don't think we have a lot of issues there. Nutritionists are also a new group that we have started issuing NANI points, and so far so good. Then, of course, nursing, I think it's very important for people to know, once the email has been sent, that point is only valid for 48 hours. After that, it's no longer valid. So kindly check your emails after a session, and make sure you upload it within the 48 hours that it has been issued. So again, we are very grateful for all of you listening in and taking your time. And we are very sorry for the inconveniences caused in terms of CPD points. But as usual, we are working very hard to make sure all of these things are resolved. Then lastly, we have the Patient and Family-Centered Care Symposium. This is a one-of-a-kind symposium that is being done by the Healthcare Quality Division. And the theme is Nothing About Us Without Us. So if you're in Nairobi, kindly register. The link should be circulated, if it's not already circulated, on our social media platform. You can check it out on Twitter. You can register either virtually or you can register physically. Then I'm sure the communications will be done for physical attendance before the actual day. So thank you very much, everybody. Have a lovely day.
Thank you.